Good morning or good afternoon, wherever you are today, and welcome to CHEST Clinical Perspectives webinar on delays in diagnosis. My name is Rick Perez. I'm with CHEST Analytics, and I'll be your moderator this morning. A few housekeeping things before we get started. This will be a 1-hour session. Shouldn't take the full hour, but it should be very informative within that hour. We will be recording the discussion, and all attendees will be emailed a link to the recording in about 1 to 2 days. Currently, all attendee phone lines are muted until the live Q&A portion at the end. But if you do have a question during the presentation, please do ask them. There is a control panel on, it should be the right of your screen on GoToWebinar that allows you to ask a question. So please go ahead and type your question in, and then if it's appropriate, we'll go ask the question of the panelists during the presentation itself. So right now we're gonna unmute all phone lines to see if there's any questions, any issues with logging in, things like that. Any questions? Anything we could troubleshoot real quick before we get started?
None on my end.
Okay, great. So we'll go mute the lines. And we will get started. So again, good morning or good afternoon, and welcome to the CHEST Clinical Perspectives webinar. Again, my name is Rick Perez, and I'll be the moderator for today's presentation. This is actually the follow-up to a live discussion to CHEST's new and very insightful issue of Clinical Perspectives, which was just released yesterday. It is on delays in diagnosis, barriers to efficient and accurate pulmonary evaluation. To begin, I'd like to introduce our panelists for today. Leading our discussion, we are very fortunate to have Dr. Patricia Rivera. Dr. Rivera is both an educator and a clinical researcher. She is a professor of medicine in the Pulmonary and Critical Care Division of the University of North Carolina at Chapel Hill. In addition, she serves as the director of the university's lung cancer screening clinic and pulmonary function and bronchoscopy laboratory, and is co-director of the multidisciplinary thoracic oncology program. Dr. Rivera considers the lung a beautiful organ and is still fascinated by it. Her special interests include care of patients with lung cancer, immunocompromised hosts, lung cancer screening, novel approaches for early detection of lung cancer in high-risk patients, chemotherapy, and radiation-induced pneumonitis. Her important research has focused on lung cancer, immunocompromised patients, and fluorescent bronchoscopy. Dr. Rivera's many honors include the first annual Pulmonary and Critical Care Division Faculty Teacher of the Year Award, 2017 to 2018, the CHEST 2017 Presidential Honor Lecturer, and she is considered among America's best doctors from 2009 to present 2018. Welcome, Dr. Rivera. Our other panelist is Mark Rudzinski. Mark is CHEST's research strategist for conducting primary, qualitative, and quantitative research. Mark has more than 25 years experience in conducting healthcare research on both the client and consulting sides. He works closely with health systems, public health, and health advocacy agencies, and with payers, conducting formative and summative research to develop brand, product, service, and experience strategies. Mark has managed research projects with the CDC and CMS and has disease state experience in cardiovascular, oncology, immunology, respiratory, orthopedics, and women's health. Within the specific category of care management, he has conducted research to support the development of stroke protocols, CHF management, and minimally invasive joint replacement. Welcome, Mark. So before we get started and review today's agenda, Dr. Rivera, do you mind giving some opening remarks about the research that we did and this important topic. Dr. Rivera? Dr. Rivera, are you on mute? Dr. Rivera, we're having trouble hearing you. Can you check to see if you're on mute?
Hi, this is Mark Rudzinski. While we're working to get Dr. Rivera back online here, I would like to move ahead in respect for everybody's time here and just give you some of the background and methodology on the study itself. Our focus today is delays in diagnosis and barriers to efficient and accurate pulmonary evaluation. As we know, a large percentage of patients with pulmonary disease and other pulmonary issues oftentimes experience misdiagnosis, and the misdiagnosis results in the failure to receive appropriate treatment. And these delays can be not just weeks or months, but in some cases it may even be a question of years. And obviously that has a detrimental impact to the potential of therapy. One of the main factors that we've seen consistently is that so many patients in this category present with very similar types of symptoms, whether it's shortness of breath or cough or other symptoms, that makes it very easy for some of the initial clinical activity to oftentimes focus in on a common diagnosis that may not in fact be the correct diagnosis, and this could be asthma or COPD, et cetera. What we're also seeing, especially as we get to some of the more complex diseases, we're also seeing a significant issue around frontline knowledge as it relates to these issues and how some of these very common symptoms might manifest themselves as they in the presence of that disease, as opposed to some of the more common alternatives that many patients land on. That's the genesis of our choice of focusing this particular issue on of clinical perspectives on delays in diagnosis. Our objectives in the research today are a few things. One, to really look at the issue of delay in diagnosis from the pulmonologist perspective, to understand how our field is defining delays and what their experience with delays has been. Secondly, we want to also focus on the perceptions of the prevalence of delays in pulmonary diagnoses, and with a particular look at lung cancer, COPD, and then the umbrella of ILD. We want to look at some of the different factors that appear to be driving delays, both overall across the pulmonary space, as well as when we start looking at some of these very specific conditions. And then lastly, what should we be doing about it as a field? What actions should we be taking to reduce delays in diagnosis?
Hi, Dr. Rivera, have you been able to reconnect?
Okay, we're still working on it here. Let's get into some of the mechanics around the methodology before we launch into a review of the actual results itself. This issue of pulmonary or clinical perspectives we use the same basic methodology, survey sampling methodology that we've executed over the last number of issues here for those of you who've been on the line with us before. This is the results we're going to be looking at today are a function of a random sample of U.S.-based pulmonologists. The sampling frame is the Chest Analytics database, which consists of members of CHEST as well as other pulmonologists practicing in the United States. We had a final sample of 106 completed responses. The survey was executed online in a similar fashion to how we've done this entire series, and the results were collected back in the latter part of September. So fresh off the presses here, so to speak. As usual, we have employed a range of descriptive statistics to take a look at the overall results, but then we've looked at a number of key cross sections of subpopulations here, whether it's physicians practicing in academic versus community-based settings, whether it's physicians who are primarily playing the role of solo diagnostician versus working within a multidisciplinary team setting. We're looking at tenure and all of the basic kind of crosscuts that we've typically done here. And our goal is to begin to understand, are there variations in knowledge, attitudes, beliefs, and behaviors when we look at some of the different cross-sectional groups here. Before I kick it back over to Dr. Rivera, I'd like to just take you very quickly through a profile of our respondents here, so that you have a good base of understanding in terms of who participated in the survey here. First off, as I said before, this is a survey of U.S.-based pulmonologists, and you can see that 72% of roughly 3/4 of our sample indicated that their primary practice is as a general pulmonologist. A fourth of respondents are primarily in a critical care setting, but as we've seen in a number of our surveys, obviously a lot of these individuals also have an office-based practice as well. On the right side of the slide here, in terms of practice setting, you can see that we've got a nice rough here in terms of clinicians who are working in different environments. We have a substantial base of physicians working in an academic medical center environment, 41%, but more than half are out there in the community seeing patients day in, day out. Some of the community settings are pure community hospitals, and some have a degree of academic program on site there. So again, we've got a good cross-reference of clinicians here from the different practice environments. In terms of just a couple of other descriptive elements here, you can see by tenure, we've got a nice even split of physicians who are, earlier on in their careers, less than 10 years out of fellowship, versus physicians who are more experienced in their careers. And as you can see at the bottom of the slide there, roughly 2/3 of our sample is, practicing in primarily an urban metropolitan area environment, and a fourth are in a suburban practice setting, and we've got a small contingent of rural-based pulmonologists as well. So with that sort of descriptive overview in place, I would like to turn it over to our expert contributor here, Dr. Rivera, for a walkthrough on the results.
Can you hear me?
Yes.
Loud and clear.
Okay. All right. Thank you so much. I apologize for that. Don't know what happened. Excellent. Thank you so much for the background and reviewing the data, Mark. We found that 74% of those who responded to the survey stated that they were the primary clinical diagnosticians when it comes to evaluation of pulmonary symptoms in the patients that they see. Respondents in community-based settings were more likely to say that they function as the primary diagnostician versus those in the academic-based practices. But it's important to note that 26% of all of those who responded to the survey, so this includes individuals both in the community-based setting and individuals in the academic-based practices. 26% responded that they were part of multidisciplinary teams when it came to discussions regarding symptom evaluation and diagnostics for common pulmonary diseases. Next slide. Many of the pulmonologists who responded to the survey define a delay in diagnosis relative to the amount of time between the time that the symptoms presented and the time that the correct diagnosis was made. And this slide breaks down all of the differences in those delays. And one of the most important, of course, is this inappropriate time delay. Patient develops symptoms, and it takes a long while before the accurate diagnosis is made. Many of the physicians felt that this was concerning regarding potential progression to irreversible disease during that time. And one of the key factors, I think, in delay in diagnosis based on symptoms is not getting the appropriate tests that are required to confirm the presence of chronic obstructive lung disease, to evaluate a chest X-ray looking for a parenchymal abnormality that might be suspicious for cancer, in obtaining that high-resolution CAT scan, which is critically important in order to identify interstitial lung disease. Misdiagnosis and wrong treatment for a condition that is not the right condition results if you don't do appropriate testing. So if you're a persistent cough for 6 weeks and 8 weeks and 10 weeks, and the patient is given the diagnosis of asthma, and that symptom isn't getting better because you're not thinking about potential diagnosis of lung cancer or interstitial lung disease or just chronic obstructive lung disease, is very important. And I think an issue for many pulmonologists, and clearly when we talk about primary care physicians, is really the non-specific nature of many of these symptoms. And often, they're not just symptoms that are associated with one specific disease. Even within the spectrum of cardiac and pulmonary and other disease processes, many of these symptoms, such as dyspnea, may overlap. Next slide. A substantial majority of those who responded to the survey either strongly agreed or somewhat agreed that delays in diagnosis were impactful. They were significant in terms of patient outcomes. What is quite interesting in the response to this survey is that a significant minority, 33% of pulmonologists, did not feel that a delay in diagnosis impacted patients' outcomes. And I found that very intriguing and was not expecting that. And I think, again, these results are very helpful in terms of what we do with this data and how we can improve primarily education as we move forward.
Yeah, we did a little bit more digging into this particular issue here, and sometimes I think it's easy to sort of jump to the conclusion that the academic environment is the incubator, and there's a different maybe attitude or mindset there than what we might be seeing out in the community-based practices. And what was interesting here is there was no statistically significant difference between the academically based respondents and community-based respondents in terms of this issue, this sort of attitudinal issue of, is delays in diagnosis an issue for your particular patient base? We found that, roughly that 33% figure that Dr. Rivera mentioned really kind of held up pretty well in both of those environments. So even in the academic setting, we're seeing a lot of clinicians who feel that, hey, this just isn't an issue, despite the fact that, we sort of associate a lot of these diseases. We associate delays as being almost ubiquitous in a lot of these diseases.
Yeah, I think that's very true, and it is I think it's very important data, and it really helps to break down some of the barriers that currently exist regarding where the care is based. Next slide. This is not at all surprising to many of us, but when we look at phenotypes and demographics of patients who are more likely to have a delay in diagnosis for COPD, lung cancer, or ILD, we of course find that it is going to be significantly high among uninsured patients and in patients of underserved minority groups, African Americans and Hispanics. And that for COPD and lung cancer, particularly lung cancer, which is the one cancer that suffers from the most in terms of treatment, diagnostic, and overall care disparities. So this is really not a surprising observation. Similarly, we need to think about differences in sex. It has been well reported in COPD. Women are often not diagnosed with COPD as early as men. Symptoms are attributed often to fatigue, fibromyalgia, and other disease processes before someone considers doing physiologic testing. And very much the case in lung cancer, women have a higher risk of lung cancer than men. And when we think about non-smokers and symptoms such as lung cancer, 20% of lung cancer occurs in non-smokers. And those non-smokers who develop lung cancer are more likely to be women. So unexplained symptoms or symptoms that persist and don't respond to treatment for asthma or allergies need to be considered for possibly explaining another disease process. And if you don't recognize that certain individuals have a higher risk or may be a risk for a disease when you're not thinking about it, such as lung cancer in non-smokers, it can be a significant delay. Next slide. The diagnosis in primary care without adequate supportive testing is a key factor, without doubt, in delays in diagnosis. And the common symptom is that of a dry cough or even dyspnea. And many, many times these patients will be diagnosed with allergies, asthma, even COPD without physiologic testing, but also important because they're not given the appropriate treatment, aggressive treatment for COPD. That is something that in my field of lung cancer, that's what I experience, is the persistent cough that doesn't get better after several weeks, and no radiographic imaging. Chest x-ray, which is a wonderful first step to look for an abnormality in the lung, the pleura, et cetera, is often not done. When it comes to interstitial lung disease, an environmental exposure history is critically important, but detailed histories about environmental exposures, particularly exposures to fungus, birds, things that are clearly linked to hypersensitivity pneumonitis, that kind of detailed history is often missing from a patient's clinical evaluation, primarily when they are being seen by primary care physicians. And again, attributing the symptoms, which are for the most part very nonspecific, to another disease process, and then there's a delay in follow-up if those symptoms have improved, given this disease that you have assigned to them, can particularly impact. And once again, we see this uninsured population. This is a huge problem in healthcare, particularly in lung diseases, and in lung diseases that are linked to tobacco exposure. Next slide. Lack of imaging, despite persistent symptoms, is critically important. And again, awareness that certain individuals may be at increased risk for certain diseases is incredibly important when it comes to lung cancer and COPD. And lung cancer in particular, again, focusing on women are more likely to be at risk for lung cancer women are more at risk for lung cancer than men, non-smokers. And also we think about lung cancer and smoking, and we think about that risk in heavy, heavy smokers. But we can see lung cancer 25 years after a patient has quit smoking. That's been very well reported. And not getting imaging studies, particularly chest x-rays, which are an excellent first step, can be a significant delay. And once again, we have the cough, the dyspnea attributed to another disease process that then prevents that causes a delay and delay in the accurate diagnosis. I find that at least in the case of lung cancer, the symptoms persist, a diagnosis of another disease process is made, but then there isn't that reevaluating of whether that symptom has improved. Or worse, the symptom is getting worse and it's not being reevaluated. And because many of these symptoms are nonspecific and can be shared with other disease processes, for example, coronary artery disease can cause dyspnea. Well, patients with COPD can have dyspnea because of COPD or coronary artery disease. And if a patient has a known history of heart disease, the COPD may be sort of in the back of somebody's mind, but never really be addressed. Next slide, please. And,
hey, Dr. If I could, I wanted to chime in. You know, a couple of the points that you made on the last couple of issues of clinical perspectives, you know, the data it completely supports that. If you think back a couple issues when we did look at ILD, the extent to which detailed environmental histories are being taken at the primary care level as well as at the pulmonologist level were remarkably low, which obviously contributes to sending the patient in a different direction. And then certainly in the last issue, we saw, to your point about some of the symptoms and where that might lead, depending on where the initial referral went from primary care. If it went to cardiac, it would, or to a cardiologist, essentially the patient would go down the cardiology workup and go completely down that path, and however many weeks or months that might take before then going back to the pulmonology piece. And what we saw is there was really kind of a fork in the road in the eyes of the primary care of, is it a cardiology or a pulmonary track that the patient should go down? And really that multidisciplinary approach right there was often lacking unless the patient had access to a multidisciplinary diagnostic clinic, which we know is kind of in the minority of settings at this point.
Agree, particularly when it comes to COPD and ILD. It's not in the minority for lung cancer. Multidisciplinary programs have been in existence for almost 20 years, but for other diseases, it's not as robust. And I just want to also point out, when we talk about lack of, gaps in knowledge about what these symptoms potentially may mean, not only in the clinician setting, we also have to think about patients' lack of knowledge about what a persistent cough could mean. They may not think that it is something to be concerned about because, hey, it's allergy season and everybody coughs during allergy season. So I think when we talk about gaps in knowledge of what these symptoms might be related to, it's across the spectrum, not only in the healthcare system and across healthcare providers, but also with patients. And the next slide talks about specific drivers in the delays in the diagnosis of interstitial lung disease. And as Mark highlighted, this lack of informative and detailed environmental exposure history is critically important. Hypersensitivity pneumonitis it happens, it's common, and if we don't ask the right questions, we're not going to find the offending agent, we're not going to remove the offending agent, and we're not going to get to a diagnostic procedure that will help identify the true diagnosis and intervene at an earlier stage. And I think that with interstitial lung disease, it is more difficult because it is such a complex group of disorders, if you will. I think even for pulmonologists, we struggle with this very broad terminology of ILD, and we all know that there are so many subsets and so many disease processes like collagen vascular diseases, chronic aspiration, chemotherapy drugs, radiation drugs, other drugs that may cause interstitial lung diseases. And I think for the primary care physicians, it must be even more daunting. And if you're not thinking about interstitial lung disease, you're not going to do the appropriate tests. You might order spirometry, but you should really also be ordering lung volumes and a diffusing capacity, a 6-minute walk test, because often these patients will have hemoglobin desaturation when they exert themselves. You should be thinking about a high-resolution CAT scan, because sometimes a conventional CT scan with 5-millimeter cuts may not give you the radiographic findings that you need to better define an underlying interstitial lung disease process. Next slide. The education is really considered, in my opinion, to be the most effective intervention. And when you think about education, it's really across the entire healthcare spectrum, as well as at the level of the patient, right? We really need to highlight what these symptoms may mean. And before you even get to symptoms, highlight potential risk factors for these disease processes, right? What are the risk factors for lung cancer? It doesn't have to be smokers of 30 packs, someone who smoked 25 years ago, family history of lung cancer, non-smoking women with a family history of lung cancer, a history of another cancer like bladder or head and neck. So it's really educating about individual risks, and not for interstitial lung disease, it's the exposures in the environment. For COPD, understanding not only the smoking history, but, is it someone with alpha-1 antitrypsin? This is a young person with pretty significant symptomatology who has never smoked or only has a very low amount of smoking. Why do they have such significant symptoms? Maybe you get a chest x-ray and you see marked hyperinflation. Why is that? So we really need to, I think, begin with education of who is at risk for these disease, and then what are the symptoms associated with this disease, and understand that they can be very nonspecific. There's a great deal of overlap. How does the environmental history, family history, occupational history, coupled with the physical examination? If you hear rows on exam and a patient has clubbing, that's very compelling for interstitial lung disease. If there is, marked decrease in breath sounds bilaterally in prolonged expiratory phase, does this patient have significant obstructive lung disease? So it's really, and it may seem basic, but again, a lot of this is nonspecific in terms of overlap and a better understanding to reduce the knowledge gaps, better education, I should say, I think could be, is critical. And it isn't just, again, the primary care physicians, it's the nurse practitioners, the physician assistants, the nurses in the clinic, and the pulmonologists, because I think some of us are, it's just so complex, and especially if we are very focused on one specific disease, and we happen to be precepting clinic on another day when we're seeing general pulmonary patients, keeping all these things in our minds can be very, very daunting. I think sometimes developing guidelines within your practice. So if you see someone with XYZ symptoms or XYZ on an X-ray or pulmonary function testing, these are the basic tests that you should be thinking about. An alpha-1 antitrypsin, a 6-minute walk test, a high-resolution CAT scan, collagen vascular panel, hypersensitivity pneumonitis panel, I think can be very helpful, because they can really help focus and narrow, if you will, the diagnostic workup. Next slide.
I wanted to interject one thing here on the last slide of our deck here was really focused on just what Patricia was talking about, which is what investments do we need? Where do we need to focus to really get at some of the barriers to reducing delays in diagnosis here? And as you look at the data slide here, you see the mean rank scores, and obviously the lower the number means that the higher that it was ranked. You can see that in our survey results, PCP education around just the disease itself and certainly appropriate testing approaches came out as being the two most important things that need to be done to address this issue. Certainly a better understanding of just clinical signs and symptoms of different pulmonary diseases, again, kind of a subsegment of the first issue here, came out the highest. we sourced these different tactics and these different types of interventions off of a literature scan of what's being done today to try to address issues around delays in diagnosis. The one thing that I think is kind of interesting here, and it goes back to that 33% figure of pulmonologists who are saying that, delays in diagnosis are not something that I feel are impacting my patients that much. I think the missing piece here is that it's not just about primary care education. It's really about education within our own field itself to raise awareness about the magnitude of the issue around delays, which is something that I don't think that there's been a tremendous amount out there relative to the inclination to say, we really need to focus on primary care, and because they're the first line of defense here. They need to be ordering certain tests at a certain juncture. There needs to be, they need to adhere better to algorithms that are out there. We need to look within our own field and see what the educational opportunities are in that environment.
Absolutely. I agree 100%. And again, we focus on, the primary care physician, but a lot of these patients are being seen by general pulmonologists. And if we're not really thinking about multiple different processes or the potential for these diseases, because this patient may be at risk, we'll miss it. So diagnostic delays may be more the norm than the exception among patients with pulmonary diseases, particularly the common pulmonary diseases such as chronic obstructive lung disease, lung cancer, and interstitial lung disease. The reasons for delays in diagnosis are variable. Primarily, it's a lack of awareness and knowledge about risks for these diseases, underutilization of appropriate diagnostic modalities, both physiologic testing and radiologic studies that can help diagnose these at an earlier stage. Contributors to lung cancer delays in diagnosis include lack of symptoms in early stages, the fact that some lung cancers grow very, very slowly, and that lung cancer can develop in non-smokers. This is something that we really have to, this message has to get out, not only to healthcare providers, but to patients. Interstitial lung disease are very, very challenging. The signs and symptoms, again, non-specific and can be attributed to a wide range of not only respiratory diseases, but non-respiratory diseases. And these delays can impact outcome. If you have a patient with small cell lung cancer and there's a delay in diagnosis, this is a tumor that can progress very, very rapidly within weeks. So if you're not in tune and getting the radiographic images and getting to a tissue diagnosis and staging in the right time, this can really impact patients' outcomes. Patients can get very sick while waiting for the right diagnostic procedures that can impact their performance status, which can impact their ability to respond to therapies. With interstitial lung disease, the critical factor is identifying what may potentially be driving, especially if it is an environmental antigen such as mold or birds in the home or birds in my grandmother's home, and I'm constantly there taking care of my grandmother, because you must remove that offending agent. That is critically important. So again, if we're not thinking about this, we're not only going to delay in diagnosis, but potentially delay important interventions that can prevent further progression. Next slide. The approach to the diagnostic process appears to have some impact on perceptions of delay between the solo diagnosticians versus the multidisciplinary team. But again, it's important to remember that 26% of all respondents, which included individuals both in the academic setting and in the community setting, had access to multidisciplinary discussions. Respondents identified primary care as a point of concern, and I think that is critically important because often the primary care physician is the first clinician, healthcare provider that an individual sees, and if symptoms are not recognized to potentially mean something else, or the fact that it hasn't improved or the fact that it's getting worse, and there's a delay in referral to the appropriate subspecialty and then further delays in diagnostic imaging and diagnostic procedures, it could really be a long while before the correct diagnosis is attained. And a lot of this, again, has to do with knowledge gaps. And it's not because people don't care, it's just that it's just overwhelming sometimes. And how do we devise educational programs that help clinicians in our very, very busy practices be able to keep track of all of these different diseases? The failure to obtain very key physiologic testing, PFTs, are very easy to order. Most hospitals, most primary care clinicians will have access to a pulmonary function lab, and it's incredibly common to have a patient with a diagnosis of asthma without ever having pulmonary function testing done. The same is true for labeling patients with COPD without appropriate testing. And testing is important not only because it helps you confirm the presence of obstructive lung disease, but it's a way to monitor patients. Are the interventions that I am giving that patient resulting in improvement? Often what we see is, hey, I treated the obstructive lung disease. Look, and if you did get PFTs, the PFTs are better, but the shortness of breath isn't better. Oh, well, maybe because there's also interstitial lung disease. So it can be so incredibly helpful, not only in terms of the initial diagnosis, but in response to therapies that you institute because you believe that disease process is the only disease process that may be going on in the patient. Because remember, some of these can overlap. And if the symptoms don't improve, or if there is a temporary improvement in symptoms, that can delay further testing because it can be misleading. Next slide. Pulmonologists feel that there is a significant opportunity for improvement in this area by raising awareness and improving knowledge so that we can close the knowledge gaps. And perhaps that is with better algorithms or clinical protocols that can be disseminated to primary physicians. It's not altogether clear, but there is an opportunity to improve this particular aspect of pulmonary diseases. It is less clear what and how we can improve in our own subspecialty, but I do think that we have many avenues in terms of national programs, webinars that we can really utilize to try to get the message out. Again, and it doesn't have to be very detailed, but if the symptom has gone on for X, Y, and Z, this is what you should think about, and this is what you might want to consider. I do think that there are opportunities within our own profession to improve. We are plagued by the crisis in healthcare in the United States of uninsured patients, and patients of low socioeconomic populations, patients who are African Americans, Hispanics. They don't have access to healthcare. And even when they do, and this has been well demonstrated in lung cancer, even when African American men with insurance are seen and are diagnosed with early stage lung cancer, they're less likely to be offered surgery than a white man. So these disparities are real, and they are across multiple different levels: the physician level, the system level, and the patient level. And we have to always be thinking of ways to eliminate those disparities. What I found very interesting about this, that 33% of the pulmonologists who answered this survey did not feel that a delay in diagnosis of any of these three diseases impacted their patients' care. And I think this really needs to be further explored. Next slide. Oh, great. We're time for question and answers.
Time for questions and answers. So at this point, we'll open up the phone lines, unmute the attendees for any questions that you may want to ask verbally. We also did get a handful of questions during the presentation So we can ask some of those while we're waiting for those to speak up. But before I do that, any questions from the attendees? Okay, we have a shy audience, but hopefully these questions that people have typed in would help others ask theirs. So the first question, in your opinion, Dr. Rivera, what types of education or training do PCPs need in order to help them make more accurate and earlier diagnosis of respiratory ailments? So I think this one, I think both you and Mark really addressed the fact that there's a need for education, but in your opinion, Dr. Rivera, do you have any specific types of education in mind?
Well, I think at national meetings, there are always, at least in our, I'm thinking of CHEST, for example, meet the professor, tumor board discussions, unusual diagnoses, or how to tackle a symptom. We tend to do these really wonderful smaller group educational sessions that I personally have found incredibly helpful. Not being a member of a primary care or the Academy of Family Medicine or internal medicine, I'm not sure what is available at the national meetings, but these are wonderful opportunities for clinicians to participate and learn about management and early diagnosis. I was recently in September at the International Lung Cancer meeting in Toronto, and I conducted a similar small group session with a medical oncologist addressing immunotherapy and chemotherapy-induced lung injury. And it was really wonderful. It was very much not just a didactic session, but the audience participated and engaged. We brought cases to discuss. And it really was, I found, incredibly useful for practicing clinicians. And these were pulmonologists, radiation oncologists, medical oncologists in the audience to better understand what the symptoms are, how to diagnose immunotherapy-induced lung disease, what to be thinking about, what to do before it happens, how to monitor patients. So there are many opportunities available, I think, at national meetings. Sessions like these, webinars that tackle one specific problem, right? What to do with, if you can even just, who is at risk for lung cancer? What do you think of when you see a patient who potentially may have a symptom? Or when should you be thinking about lung cancer in patients who present with a variety of symptoms? What kinds of questions to ask when you have unexplained shortness of breath? And be thinking about not just coronary artery disease, but perhaps that exposure to birds that might be causing hypersensitivity pneumonitis. I think most of us are so overwhelmed on a day-to-day basis in our clinic. We don't have time to sit and read, volumes of literature. We do that when we go home, and when we have more downtime in clinic, having a way to access, quick shortness of breath or cough in a patient with X, Y, and Z, think about X, Y, and Z algorithms, if you will, that can help us, I think can be very useful.
One follow-up that just came through here. Is there a role for industry to play in the educational effort here? Because when I think about when you look at these diseases here, there's so many therapies coming online that are having an impact. But what we're dealing with is a delay in getting to those therapies because of the diagnostic issues that you've highlighted here. Is there a role for industry to be playing in terms of education? I guess both at the primary care level and at the pulmonologist level.
Absolutely. I have participated in many industry-sponsored webinar series that tackle one specific issue, pertaining to lung cancer, is tissue acquisition and what to do with specimens and what to look for and what to send these specimens for in terms of molecular diagnostics in hopes of optimizing the molecular diagnostic testing, identifying patients who have driver mutations, and getting patients so that properly identified so they can receive the proper targeted therapy and personalized therapy. And those are incredibly useful. I participated in one. It was me and a pathologist. And it's this exchange of ideas of what the pathologist needs to know and hear from the pulmonologist and what the pulmonologist needs to know and hear, and how do you communicate? Because a lot of this is about communication. And I think personally for me, I've listened to many of these webinars, primarily centered around the treatment of lung cancer, webinars that have been hosted by medical oncologists and radiation oncologists, because you learn a great deal often when you hear people discussing. Again, you have to always go back and read the textbook, read the key articles. But sometimes when you hear discussions and this back and forth exchange of ideas, I think, and if it flows well, it can be very, very, for me, very, very helpful.
Great. We have time for one more question. I have one here, but is there a question from the audience at all? Okay. Well, here's one that was sent in. Dr. Rivera, in which disease state, lung cancer, COPD, or ILD, do you feel that a faster diagnosis is the most crucial, and why?
Well, I think, I'm a lung cancer, primarily pulmonologist, although I do see a lot of patients with COPD and ILD. Lung cancer is important because, you have to think about small cell lung cancer, which is 15% of all cancers, but you don't want to wait. That's a disease that can progress very, very rapidly, and patients can get sick. If you have a small tumor that's growing slowly and the patient is asymptomatic, that's a different story. But you have someone with cough, hemoptysis, progressive dyspnea, pleural effusion, potentially small, so that patient can progress very, very quickly, and symptoms can lead to worsening performance status, which can impact the ability to tolerate more aggressive therapies. I think with interstitial lung disease, it is critically important to think about exposures. It isn't just about appropriate diagnosis, but it's also about removing a known potential exposures that may be driving that underlying interstitial lung disease process, whether it be a drug, exposure to birds, etc., because that often is critically important in terms of halting disease progression. For chronic obstructive lung disease, it's about appropriate therapies, the role of pulmonary rehab, getting patients evaluated for hemoglobin desaturation with exertion and at night. These are all interventions that can prevent further damage, and more importantly, if patients are still smoking, a terrific opportunity, a teaching moment to try to engage patients in meaningful tobacco treatment, counseling, and therapy, because we know it is incredibly helpful not only in COPD, ILD, but in lung cancer. Hello?
Yeah, thank you for that, Dr. Rivera. And Mark, I think this was a very informative discussion, very valuable to the audience. And so with much gratitude, thank you for participating and really putting together a good study, white paper, and presentation. Also want to thank all of those that attended today. On the screen is additional information on the CHEST Clinical Perspective Series. So if you're interested, please follow those links. And again, thank you to the audience and to our presenters, and happy holidays.
Thank you. Thank you, Mark, and thank you, Rick, and to the audience for participating.
Great. Thanks. Thank you.
Have a wonderful day. Bye-bye.